Hi, my name is Sapna Kudchadkar, and I am thrilled to speak to you all today about Pick You Up, creating a culture of mobility for critically ill children. Let's get started. Overview of our objectives and agenda for today. First, we're going to start by discussing creating a culture of mobility for kids. We'll introduce integrating the ABCDEF bundle using the Johns Hopkins Pick You Up program as an example. We will share available resources there for our global ICU rehab community, including explaining the upcoming virtual 10th annual Johns Hopkins ICU Rehab Conference. And finally, we'll end with the best part, which is the discussion, the interactive Q&A, learning from the experience of our interprofessional community.
We have our discussion and Q&A with Allison Marsh from Nursing, Stephanie Hazen from RT, Carrie Potter from Child Life, and Hallie Lenker from PT. These are our incredible Pick You Up champions, just to name a few, who are going to share their interprofessional perspectives during the live Q&A. September is Women in Medicine Month. We want to highlight the Pediatric Critical Care Women's Speakers List, an interprofessional list of over 450 names, and we want to see you on it. All professions invited so that you can share your expertise, and people look to this list when they're looking for experts in ICU rehab especially. So please do check it out. To add your name, you can go to bit.ly/Pick You Women Speakers Form. And if you want to view the list, you can go to bit.ly/Pick You Women Speakers.
A quick reminder that this free ICU Rehab webinar series has 3 other webinars in it, and they are all already archived. They happened earlier this month, and those include post-intensive care syndrome, hospital-wide activity and mobility promotion, and COVID-19 long-term outcomes. And all of those webinars, including today's, are archived at ICURehabNetwork.org, and you can just go to free webinars that's highlighted in red there. Anyone who knows me knows I'm very passionate about professional social media in the pediatric community. So please do engage with hashtag PedsICU, hashtag ICU Rehab, and follow me on Twitter at SapnaKMD. And also, obviously, very relevant to current times, hashtag COVID-19. Whenever I give a talk about the importance of early mobility in the pediatric intensive care unit, I like to take a step back and think about the fundamental requirements for a child to grow up healthy. They need good and nutritious food, they need shelter, they need love, and they need to sleep. Sleep is a critically important part of brain development. In addition to those 4 basic aspects, children also need to play. Play is crucial to emotional, cognitive development because that's how children learn to interact with the environment around them. As I'm sure you're all aware, this is often the picture, however, that we see in the pediatric intensive care unit. A child who is completely immobile, multiple infusion pumps next to their bed, a fluorescent light above their head, on invasive interventions, including ECMO and the oscillator, eyes closed, seemingly comfortable. However, we've noted that there are many studies that have shown that immobility is a problem. And so we have the prevalence of acute rehabilitation for kids in the PICU study that has been conducted in the United States and the European Union, as well as in Canada, and also data is coming out from Brazil very shortly. And what we found is that only 35% of all patients on any given day receive therapy from a physical or occupational therapist. And 20% of these patients, 1/5 of these patients, are completely immobile on any given day. Even more surprising and unfortunate is that children with higher baseline function are most likely to have delayed rehabilitation. And in the United States, at least, girls and younger patients had lower odds of PT or OT provided mobility. So we have this culture of immobility. So let's talk a little bit about why. ICU liberation is not a new concept. I love this quote from JAMA in 1899. It means a great deal to be put on their own feet in a short time rather than be confined to bed, having their weak backs and general debility increase rather than disappear after the operation which was to cure them. Dr. Emil Rees, JAMA, 1899. JAMA, 1944, the abuse of rest as a therapeutic measure in surgery. Prolonged bed rest is anatomically and physiologically unsound. Early restoration of medical and surgical patients to normal life is an essential feature of modern convalescent supervision. So what changed? We were talking about mobility many moons ago. Well, we got really good at saving patients' lives. Increased survival meant technological and scientific advances, bed rest to promote stability and safety, and continuous sedative and paralytic infusions, which helped us to facilitate this whole notion of rest and recovery. I love this quote from Thomas Petty in 1998. What I see these days are sedated patients lying without motion, appearing to be dead, except for the monitors that tell me otherwise. By being awake and alert, they could interact with family, feel human, and sustain the zest for living, which is a requirement for survival. I think you would all agree that often the patient experience and the family's experience and expectations are often different from the reality. The reality is many steps forward, sometimes even more steps back, while the family and the patient often expect them to come into the hospital and for us to make them better, and then they'll go back to the same quality of life. We have many colleagues across the world who are looking at this post-intensive care syndrome and what that means for children who are survivors of pediatric critical illness. And if you look at one paper focused on PICS-P, as we call it, post-intensive care syndrome in pediatrics, you'll see this beautiful conceptual framework by Manning et al. In PCCM 2018 that shows that physical, cognitive, emotional, and social health are impacted substantially, and that is capitalized on by developmental impact, which impacts the trajectory of recovery. My colleague Karen Chung in Canada has done exceptional work looking at outcomes post-ICU care on the physical and functional realm. And you can see here that it's not just the patients who have normal baseline function that have the issues, it's not just the patients with severe disability that have the issues, it's also the patients with normal baseline function, patients who were great athletes, had straight A students before they came into the ICU with ARDS or some other illness. These were the patients. Over 40% of them had not returned back to baseline by 6 months after their illness. So we can't just focus on survival anymore. We have to focus on survivorship. The Society for Critical Care Medicine has created the ICU Liberation Bundle. Is it as easy as A, B, C, D, E, F? Assessing, preventing, and managing pain, spontaneous breathing trials, choice of sedation, delirium monitoring and management, early mobility and exercise, and family engagement and empowerment. It all makes sense, right? In fact, our adult colleagues have actually demonstrated in over 15,000 adult ICU patients that the implementation of an ABCDEF bundle improved mechanical ventilation duration, coma, delirium, and use of physical restraints. And what's really important to note here is that it wasn't enough just to use one bundle. You had to use all of the bundles together. And as you use them together, they combined as an intervention to improve outcomes across the board. So what about the kids, right? Why can't we just take the ABCDF bundle and use it for all children in the intensive care unit? Well, there's probably nowhere else in the entire hospital system than the PICU that's more heterogeneous in terms of ages and development, for example. We worry about the tube falling out. And we worry about remembering their PICU stay. We're doing all these invasive interventions. Isn't it bad for them to remember? Well, let's talk about that. Because often this is our approach. It's less about the patient's comfort and more about our own comfort. When I see orders to titrate sedation to comfort, I'm certain they mean my comfort, just so you know. So essentially, we've created this vicious cycle phenomenon where kids aren't sleeping, so they're given more sedation. The sedation needs escalate over the duration of their intubation. Their sleep quality worsens, and then they get delirious and more agitated. So what do? We give them more sedation. And this leads to physiologic dependence and prolonged hospital stays for withdrawal, often for methadone and Valium weans. We actually looked at this not only in the operating rooms, though, in the PICU with regards to sedative and anesthetic neurotoxicity. You know, as I'm a pediatric anesthesiologist, and you can imagine every day I get questions from families about whether this 2-hour anesthetic will impact their child's IQ. What about an anesthetic for days, weeks, even months in the intensive care unit environment? So I'm here to tell you that it's never too early. It's never too early for us to take a minimal but effective approach to so many aspects of our ICU care. We want to keep patients comfortable, cooperative, and calm. We want to focus on analgesia first. We want to minimize sedative exposure, and we want to provide humane, person and family-centered care. And this is a beautiful framework from UCI that really demonstrates all of the components associated with that. So really, it all begins with sleep. I mentioned that sleep is critically important to brain development and healthy childhood. So let's talk a little bit about that. Why should we care about sleep in the hospital? Well, natural sleep is integral to physiologic homeostasis, including all of the different organ systems in our body. And the principal concept here is that sleep is an evolution of brain maturation, and brain maturation is an evolution of sleep development. Basically, as sleep trajectory changes over time, children's brains are changing actively too. In fact, though, our adult colleagues have actually been the first ones to incorporate sleep into their typical ICU care algorithms. In 2018, they added the immobility and sleep disruption guidelines to their clinical practice guidelines. So I'll ask you here, these two children seem very comfortable. They're clearly immobile. Are they sleeping? Their eyes are closed. Are they experiencing that natural restorative sleep that's so critically important to brain development? Well, the answer is that they're not. This is a study we did in children receiving opioids and benzodiazepines in the PICU. We age and gender matched them to a child that was healthy out in the community. And you can see here the healthy children have this beautiful ultradian rhythmicity of their sleep-wake patterns over the course of a night. And here on the bottom, no ultradian rhythmicity or circadian rhythmicity at all. Not surprising, but the first objective data that we had on sleep characteristics in intubated children who are receiving sedation. We all know there are multiple reasons for children to have disturbed sleep in the ICU. However, improving hospital sleep is not a priority. We looked at all papers that were randomized controlled trials investigating sleep promotion interventions in the ICU, and we found 60,000 abstracts that could potentially have been related. However, less than 80 RCTs, and almost all of them were conducted in neonates. PICU sleep's not a priority, just like hospital sleep's not a priority. This is a systematic review that we conducted in 2014 where we just looked for the words sleep and PICU, and we found that only 9 publications about sleep on the word PICU at that point in time. 4 of them came from the same RCT, and 2 of the studies used subjective assessment tools for sleep assessment. We subsequently did a survey looking at pediatric intensivists and their awareness of any efforts to promote sleep in the PICU. And we found that noise reduction, lighting, earplugs, eye masks were not used universally across the board, and people weren't even aware of even the most minimal efforts like protocols to reduce noise at night. What about opioids and benzos? Well, those were the primary agents that were being used for first-line sedation in critically ill patients, and less than 10% were using dexmedetomidine. So what's wrong with that? Why are an opioid and benzo-based first-line approach a problem? Well, opioids and benzos have a very important role in care of the hospitalized patient. However, they do have deleterious effects on sleep. They'll help us fall asleep, but the quality of the sleep, that slow wave restorative sleep, is significantly diminished. And we now know that benzodiazepines are an independent risk factor for delirium, not only in adults, but also in children as well. So if you were all in front of me here right now, I would ask you, what is the most common time for x-rays in your unit? And in the United States, the vast majority of people would raise their hand and say between 5 a.m. and 7 a.m. Next, we would ask them what the most common time is for baths, and most would say between 10 p.m. and 5 a.m. Why is that? Should that really be our normal? Baths at 2 a.m., x-rays at 5 a.m., labs at midnight, immobility, benzos and opioids. It's because we're hitting the easy button. We're doing what's easy for our own convenience. Less things going on at night, give a baby a bath and get their weight. X-rays at 5 a.m. so that we have them for our morning rounds. We can take a step back and optimize our routines, not for our purposes, but for the patient. This is a study that we conducted to look at sleep-wake patterns after children leave the ICU, and we found that over 2,271 hospital days using accelerometry or actigraphy, the day-night activity after major surgery showed that there was no difference between day and night in approximately 40% of the subjects. 40%. So what have we learned? Well, we've learned that sleep is a marker of brain development in childhood, that sleep is severely fragmented in children admitted to the hospital, and the behavioral phenotype of sleep fragmentation presents as delirium. So let's unpack that a little bit. Delirium is inattention. It's defined as inattention in the DSM-4 psychiatric diagnosis. And hypoactive delirium is the most common type of delirium in the pediatric intensive care unit. Traditionally, we always think of the patient who's flailing about. This is Micah. Micah had 2 heart transplants, had crashed onto ECMO multiple times. And clearly, this is Micah when he's not hypoactive delirious. And this is Micah with hypoactive delirium. He's inattentive here. And his family will tell you that this was probably the scariest time in his hospital stay, when they felt like they lost their son for a brief moment in time. So we asked our colleagues, how many of you are actually screening for delirium on a routine basis? And back in 2014, only 2% of respondents reported delirium screening is performed for all mechanically ventilated patients once per shift. In fact, when we asked these 2% what they used, barely any were using a validated screening tool. Some were using the SOFIA observation scale. Another group said they were using the withdrawal assessment tool. And those 2 tools are not validated for delirium screening. Delirium is everyone's problem. The Johns Hopkins Delirium Consortium here is an interprofessional group that's dedicated to talking about delirium across the hospital system, because we all have so much that we can learn from each other. So why should we consistently screen for delirium in the ICU setting? It's not just to diagnose delirium and treat it. Wes Ely, one of the fathers of ICU delirium work, said a positive delirium screen after several negative screens is a warning sign for impending badness. I can't tell you how many times I've had a patient who was negative for delirium screening, all of a sudden came back positive, and then 4 hours later the blood culture was positive. There was some new thing that happened. So what are our culture change goals? Every kid, every day. Get the experts to the bedside early. No child is ever too sick to turn away a physical or occupational therapist. Analgesia first, then sedation if needed. Kids and families can tell us what they need. And finally, sleep hygiene and delirium prevention can lead to more mobility. So how do we achieve that? Well, we created the Pick You Up program. So Pick You Up is an early rehabilitation and progressive mobility program. It's a structured and interdisciplinary program that's integrated into the routine care of the critically ill child. And our goal outcomes were to provide a standardized mechanism to increase activity level and improve patient outcomes, lower rates of mobility complications, decrease length of mechanical ventilation, and hopefully decrease length of stay. One thing that we needed to make sure our entire staff was educated about was that early mobility doesn't always mean ambulation. Ambulation is not the goal for everyone. We wanted to make sure our entire staff understood that we need to start with the most basic aspect, which is normalization of the sleep-wake cycle. And based on the child's acuity of illness, we could advance those goals over time. So this is just a schematic. This is all in the PCCM 2016 paper of Pick You Up and the activity progression. It's based on acuity of illness. If you are mechanically ventilated with high oxygen levels, you're at level 1. However, if you're on BiPAP with low oxygen levels, you're level 2, for example. But you can see here, regardless of how sick you are, every patient has prioritization of sleep hygiene. Lights on, shades up, bed, bath, and wait by 11 o'clock p.m., lights dimmed by 11 o'clock. Limitation of TV time. In the United States, it's not unusual to see a TV on by a 6-week-old's bedside 24 hours a day. That's not developmentally normal. Therefore, we try to optimize what is normal for a child's healthy development over time. So I'd like to finish by presenting some case studies. I'd like you to let me know if we are letting kids be kids. You be the judge. Are we letting patients be awake and alert, interact with family, feel human, and sustain the zest for living, which is a requirement for survival? I'll start with this case study. So anytime you're trying to implement a program like Pick You Up, mobility program, a major culture change for the unit, you need to start slow. You need to start with what we call the lowest hanging fruit, the patient that's going to be the least challenging to mobilize. This young man needed a VAX procedure for a severe pneumonia that was loculated. You can see he had his surgery, he has a chest tube, and he was bored. And he was on a significant amount of high flow nasal cannula, but he's also a very active guy at baseline. So we asked him, do you want to ride a bike? It's not something we'd ever done before. So he brought the bicycle to the bedside, and you can see here, he's very happy. He did the dab, and that was the first time we'd done that in the unit. Not rocket science, not some major change or activity, but for us, it was a major change, something we hadn't done before. We celebrated this with our staff and made sure everyone saw how successful this one event was. Next thing you know, we started working with our cardiac patients. This is a 2-year-old female after her Fontan procedure, post-op day number 1. And typically after a Fontan, we might let the child stay in the room for 24 hours, even if they're extubated, give them some time to quote unquote rest. However, we had just started Pick You Up, and Sydney's nurse here said, Sydney, we're going to pick you up. And you can see she's not very happy about this prospect, and you can't blame her. She has these chest tubes hanging out of her body. She has a sternal wound. She has a fresh arterial line, an IJ line, and she's tethered to this IV pole with a PCA and all sorts of other drips and her monitors. So what I'm going to show you next is how families can help us overcome a little toddler spirit to make good things happen. Her family actually said to us, well, Sydney went into the operating room in one of these cozy coupe cars. Do you guys have one of those? And we didn't have one of these little cars, so we went to the operating room and brought one. And what you'll see is how creativity can overcome toddler spirit.
You're doing so great.
It's a great exercise. Those legs. Feel the burn. Feel the burn, yeah.
Look at those legs go.
Those legs go.
Awesome.
So I don't know if you all noticed, but she's wearing her own shoes. And it's those little things that make a huge difference in feeling the comforts of home. Even if she's not ready to change into regular clothes, her shoes could make all the difference. Next thing you know, Sydney brought us our own cozy coupe car with her license plate on it, and now many children get to ride in as well. Before we knew it, we had demonstrated with the easier patients that this is possible. So it was time for us to test whether we could ambulate an intubated patient. So this was our first patient that we ambulated, a 9-year-old with alveolar rhabdomyosarcoma, intubated for airway protection, no benzo, low dose morphine PCA. And you can see here, she is walking. She played with Barbies in the playroom, and then she went back. And this patient was on a low level of oxygen, had normal baseline function. So she was the ideal candidate for this first ambulation. And we shared the story with the rest of the staff and made sure everyone saw this one success, that it was possible. Take home points for today is it is never too early. We have to value each other's expertise. Consistency is the key. There is no easy button. Analgesia first, start low, go slow. Sleep and nutrition are so important, and push the envelope safely. Anything we can do to optimize these patients' quality of life is so important. Whether or not their outcome will be what we want it to be, we can do something in the moment to improve their quality of life in the short term and even in the long term. Thank you very much. If you're interested in learning more about Pick You Up and all of the resources that we utilize on a day-to-day basis, please do go to bit.ly/PickYou_up. You can follow us, of course, on Twitter @PickYouUp and also on Instagram. There is a Pick You Rehab reference list that includes hundreds of articles specifically related to pediatric ICU rehab and the ABCDEF bundle. We curate that on a daily basis. We have an introduction to Pick You Mobility, Pick You Up in Action, lots of stories and news, and also patient and family interviews. So feel free to check that out to learn more. Reminding you again that the other 3 webinars in this series are all free and all already archived at ICURehabNetwork.org. Just go to free webinars highlighted in red. And if you want more resources and learning, you're in the right place. I'm going to hand it over to Dr. Dale Needham, who's going to do an introduction to the 10th annual virtual Johns Hopkins ICU Rehab Conference. And then stay tuned, because immediately after that, we will follow it with discussion and a question and answer session with all of you. Thanks so much.
Hi, I'm Dale Needham, Director of the 10th Annual Johns Hopkins Critical Care Rehabilitation Conference. For 2021, this is a virtual conference, and I want to explain our format to you. All of the conference content, including 75 presentations, 38 hours of content from 55 experts, is available in 2 formats. Each registrant is able to use both formats for the single registration fee. The first format is unlimited on-demand access. You can watch this conference content anytime, anywhere in the world from October 21st to December 15th, 2021. Its second format is joining the live conference. That's occurring on November 4, 5, and 6, 2021.
Thank you, Dr. Needham. We look forward to seeing all of you at the ICU Rehabilitation Conference, and keep in mind, we have both a foundations and a main conference track that is specific to pediatric critical care, so do come join us.
So I would like to introduce our incredible interprofessional panel, and I'll invite them to turn on their videos. Hi, everyone. So obviously the crux of pediatric ICU rehabilitation is the interprofessional team. And there's no question that that was the only way that we had success in getting this off the ground. And it was a challenging road, but working together, we were able to make it happen. And we continue to work through those challenges to this day. So I'm going to ask my panelists to introduce themselves. We have a nice representation from many of the teams, not all of the teams, but these are our core champions from nursing, respiratory therapy, child life, and physical therapy. So Allison, I'll ask you to go first.
Hi, I'm Allison. I've been a nurse in the PICU at Hopkins for close to 7 years. Do bedside, I do team lead, charge, and all of that. So I'm heavily involved in the unit.
Thanks, Allison. Steph Hazen?
Hello, I'm Stephanie Hazen. I am a respiratory therapist and ECMO specialist at the Johns Hopkins Children's Center. I've been here for 12 years, and I am happy to say I am one of the RT champions for our PICU Up Committee.
Wonderful, thank you. Carrie?
Hello, I am Carrie Potter. I am a child life specialist here at Johns Hopkins, and I have worked in our PICU and PCICU for the last 7.5, almost 8 years.
Wonderful. And last but not least, Hallie?
Hallie Lenker. I'm a pediatric physical therapist here at Johns Hopkins for the last 10 years and the team coordinator for inpatient and outpatient rehabilitation for PTOT and SLP.
Fantastic. Thank you to all of you. So we're gonna keep putting up the slides about how to enter stuff in the Q&A. So stay tuned for that. You'll see some rolling slides along the way. So we're gonna go ahead and kick it off when we already have some questions in the Q&A. Sneha has a great question that's been upvoted. Thank you for a great presentation. Thanks, Sneha, for that feedback. She asks, how do you balance the need for early mobility and rehabilitation with staff discomfort or limited staffing, as we've been seeing during COVID, especially? I think all of us could answer that question in one way or another, but I'm actually going to ask Allison to take that one, given that nurses, are the front line of early mobility. So Allison, what are your thoughts?
I think that you can start with the smallest things. Getting your patient up to the chair, sitting them up in bed. In terms of limited staff, I think it's also really important and just an intricate part of including the family, whether it's the mom, the dad, the aunt, the grandma that's there. They, I think, at times can be quite timid with wanting to move their critically ill child, but encouragement goes a long way. You can always stop if it's not working, but it's always a good thing to try. So I think just involving family is a huge part of it. And then just planning ahead for staff, making a schedule for the day, I think is important.
Thanks, Allison. Yeah, I think that lowest hanging fruit piece is really important. It's really cool to be able to ambulate all the intubated patients, but we know that logistically that's not feasible on any given day in any of your ICUs, I would imagine. Steph, how about the RT perspective on that? Because obviously you guys are mostly involved in the most critically ill patients.
Yes, that can be very challenging. I will say somehow we seem to always pull together as a group. If it's a big, intense activity like moving an intubated patient, PT actually usually rolls up deep with like about 3 of them. Nursing pulls together. A lot of times the buddy nurses help out. Somehow we always pull together. Child life is huge, helpful as well. I mean, I hate to say like anybody can help pull the vent circuit, but people always come together to make it happen. Family involvement is huge as well. I think that the motivation can be contagious. And once we all are just on the same page and see how helpful it is, people are willing to help out.
Yeah, the motivation definitely is contagious. And I want to make a very key point. When we started Pick You Up, and even to this day, we did not have additional resources for staffing. We're working on getting the additional staffing, but it was really a passion project because people who were invested, like the women you see on this panel, wanted to make it happen, and we worked together. So Steph, what you said is a great segue to Hallie and the rehab team. And going back to what Allison said about sometimes discomfort, not only just on the family level, but many junior nurses, for example, may not have the background or the training yet to really feel comfortable mobilizing a critically ill patient. So what is the rehab team's role in that?
Yeah, so I think typically, especially for your more critically ill patients, rehab is going to have a much more active role in, really initiating that early mobility, especially in the first couple of times. One is to make sure that the teams feel comfortable. It's really making sure that the patient and the family feel comfortable as well. I agree with everyone's point of really having the family involved. But sometimes, depending on how well that patient is doing, those family members can feel very nervous about something like mobility. And often having the rehabilitation team there can help kind of put everybody at ease, because we're much more used to just, hey, looking at the room, looking at the patient, and making those decisions. We do a lot of in-person training, so we don't have any onboarding currently with new nurses of, this is how you're going to mobilize patients. So it's pulling those nurses in that are still in orientation, having them be there, having them hold the lines, kind of helping them problem solve. Because our idea is that we hope that the next patient that is less critically ill, that they're able to start to mobilize them without us. So really trying to use those times when it makes sense. And then also really making sure you communicate with the nurse, because we'll often call in the morning and have a plan, but you never know when another patient's going to go have a bad day or something like that. So being able to kind of change our plans very quickly based on what's happening in the unit also makes us more successful, but then also builds our relationships with those nurses, because we really all have to make sure that we have a plan that we're working on together.
Thanks, Hallie. And I think what you stated just underlines how really the transformational piece of Pick You Up, other than just interprofessional collaboration, was that whole no child is too sick to be evaluated by a physical or occupational therapist ever. That really changed everything for us, because as soon as the rehab team was coming to the bedside and invited into a sick patient's bedside more often, you can imagine the nurses and the therapists started to interact more. And before we knew it, and this is a culture that I hope everyone can aspire to, is that the nurses in the morning have already got, by the time I say on rounds, oh yeah, has anyone called PT? The nurse is like, oh yeah, we already talked to the therapist. They're coming at 1 o'clock and this is what we're doing. And I'm like, oh, whoa, okay, you guys are all over it. And so physicians are great, but you need to take this out of the hands of the physicians as the primary drivers, because no matter what, in any medical culture, the first thing that's always going to be prioritized is the acute resuscitative stuff. And unfortunately, and I hope we change that, the medical team often does not put this at the top of the list, even if it is time to put it at the top of the list. So that's why we need all of you. And finally, Carrie, I think for us, it was a no-brainer that child life was going to be like central to this entire enterprise. But as you know, when we implemented Pick You Up in other centers, the child life specialists often were like, whoa, like this is something that I can own. So can you talk about child life's role, especially in the things that make a child's life more normal in the ICU?
Yeah, I think that our involvement in both providing and encouraging play experiences, but also normalizing experiences in the hospital, obviously applies to mobility and really letting kids live life as much as they can in this environment. But I think too, helping kids navigate stressful experiences, which sometimes mobility experiences can be. Sometimes I find that prior to everybody coming to the bedside to mobilize a patient, my role is to help the patient and the family come up with a plan of how are they going to cope when that happens, and what's the signal to pause or anything like that, in terms of just wrapping their minds around something that, as many people brought up, can sometimes make them feel a little bit nervous about what's happening, similarly to lots of the other medical experiences that child life specialists are preparing kids for.
Thanks, Carrie. And to answer the question about COVID specifically, I think, if we all went back to March of 2020, any of you who worked in the ICU at the time, I actually was deployed to the adult ICU. So I saw this in spades, is that not surprisingly, the COVID patients were the last to have rehabilitation team come to see them, right? Because they wanted to limit the number of staff that went in and out of patient rooms. Luckily, I think we're in a better spot across the globe, but not perfect yet. So the key is, again, it's a cultural shift. We know how to protect ourselves with PPE, et cetera. So we have a COVID patient over the last few months that was in our unit for a very long time. And for a teenager with COVID to be in a room that's completely isolated by themselves, it affects their mental health as well as obviously their physical health. And so our rehab team came to see that patient 5 days a week. That was a patient who had normal baseline function prior to coming to the hospital, and it was really important that she maintain that. So again, it's all about setting the expectation as opposed to saying, oh, this is lower priority because of X, Y, and Z. I'll take Marie's question on any differences between adult and pediatric ICU rehab first, and then I'll ask Callie for her thoughts. Overall, I think there's many similarities. I think the big difference that I had to learn about as a non-rehab specialist is that children are not just rehabilitating, they're habilitating, right? They're developing actively. And that's a word that Hallie and Yun Kim taught me actually from our PT and OT team. They're actively developing. So it's so important that they don't lose their ability to get to certain milestones. But I'll turn it over to Hallie for her expertise on this matter.
Yeah, definitely. So you think about in our pediatric population, how many children are under the age of 10 that are often either critically ill or had surgeries. And so we really want to be taking not only what were they doing before, but especially for a longer length of stay, how do we continue to move them forward? The other big difference for an adult versus pediatric population that really involves the whole multidisciplinary team is the communication. So you think about it, for most adults, there is some way to communicate either on boards or verbally of, this is what we're going to do. This, you let us know how it's going. You can be an active participant, especially for our younger children. That's really challenging, right? Babies, Sapna's big thing is babies are supposed to cry, but often with some of our colleagues and even as therapists in the beginning, are they upset or are they in pain? Are they having trouble? Are they about to have issues with their oxygenation? So really trying to kind of learn and teach our colleagues how to monitor those in those younger patients. Stranger danger is huge in that population as well. So really trying to figure out all of that is a much more of a challenge in the pediatric population compared to the adults. So it just takes, I think, a bit more time and nuance of, pulling in our child life specialists so that, we're having it as a positive experience and the people in maroon don't walk in the door and the kids start to cry because they're nervous. PTs and OTs and SLPs wear maroon at Johns Hopkins. So we really want to try to build rapport with those kids a lot more than in the adult population where you can explain why it's important.
One of the important data points here to Hallie's point is that 66% of the patients who are in the PICU 3 days or longer are under the age of 3. So again, a major difference in pediatric ICU rehab, apart from our physical and occupational therapist coming to the bedside, is, as Allison can tell you, it's therapeutic cuddles, right? So Allison, can you talk a little bit about how you make the decision of helping or even giving the parent an option to hold their child when they're critically ill? Like how does that kind of happen organically now, especially with our nursing team who brings it up all the time when appropriate?
I think that parents, as they're in there watching their child, if they're intubated, BiPAP, whatever they may be on, they're like, like I really miss holding her or him. I wish I could just hold him. And then, I mean, that just opens up a can of worms. I'm like, well, you can. Like, would do you like to do that today? Because we can absolutely make that work. And I think that they go through like a whirlwind of emotions. They get excited and then they're like, oh, but is that a good idea? So I think it's just important to like talk to them about what it looks like. There's going to be a lot of people probably, but that's okay. It's for the safety of their child. But I think more and often it just like comes up in natural conversation that they wish they could. And then we just talk about that even more. And they're always very happy. They get lots of cuddles and pictures. And it's just another way for them to live through their experience in the ICU.
Talk about making everyone feel good, right? So the parents feel good. And look, I would love for someone to do the research study. Feel free to take this idea and go with it. The number of times that we've seen a baby who is very agitated with heart rates in the 180s, 190s, and who has never been held by their parent because they've been critically ill since birth, and then they go into their parents' arms and their heart rate drops by 30 points. And I've seen tweets about it. I've seen it anecdotally. It's the real deal. There's a reason when you pick up a baby, they feel better. So it makes sense. So what we do at home can also be applied in the hospital, and that's really, really important. Sometimes parents don't even know it's okay to ask. They can't even plausibly think of that question. So it's on us to bring it up, and that's why our nursing colleagues are so spectacular in that way. Anyone else have any other comments about adult versus peds ICU rehab? Carrie, I did want you to comment a bit because you were involved when we opened the COVID units. Part of our pediatric ICU turned into an adult COVID unit back in the day. And so we were able to actually learn a lot from how adults do things, but also we were able to teach our adult colleagues some new and creative ways to optimize the entire rehabilitation and ICU experience. Carrie?
Yeah, so from a child life perspective, one thing we think about with when we are working with adult patients is their entire family unit. And during COVID, that meant family units that couldn't necessarily be present. So we use lots of virtual ways to connect kids and families together. So sometimes that meant having kids draw pictures and they would email us pictures of their pictures, and we would print them and hang them in rooms so that when nurses and other providers were at the bedside, they could use them for orienting and just boost of morale for adults in the ICU. We also used virtual ways of actually connecting to be able to Zoom or FaceTime. And then, we like to do, things like all about me's and things for people to build that quick rapport with our pediatric patients, and found that our adult colleagues really enjoyed doing the same thing. And it gave them the same ability to connect with adult patients, knowing what kind of music they like or what TV shows they like to watch. So we, had all about me posters for the adult unit for them to be able to fill out. That way, when you're talking to someone through a respirator or through a PAPR, you still can sort of figure out those common interests or those interests of the patient that allow you to connect with them a little bit more.
Love it. Thank you. Steph, do you have anything to add based on your kind of exposure experience with adult and pediatric patients?
As far as differences between peds and adult, yeah, it was very interesting. I went over and worked in the medical ICU for a couple months during the peak of COVID here in Baltimore. And I found that a lot of the adult patients, it was very interesting. They were very interested in being mechanically ventilated. And I actually had a couple patients who we did start sitting at the edge of the bed, and I would turn the ventilator towards them and show them and talk to them about the ventilator and their lungs and the settings. And I thought that was really wild, because that's something I definitely didn't think I would ever do with a patient having only worked in pediatrics. So that was different. Now, not everybody was cool, calm, and able to, and interested in the ventilator, but I thought that was kind of wild.
Thanks. That's very important perspective. I think that the key consistency, though, is that illness doesn't mean stillness for everybody, age 0 to 100 plus, right? And so every single patient needs to have their pain and sedation, their analgesia and sedation goals titrated to their individualized need and no more, so that we can optimize their ability to participate in rehabilitation. And we have shown that babies can be intubated and not be deeply sedated. I remember back in the day when I was training as a fellow, I'm not that old, but back in the day when I was a fellow, every RSV bronchiolitic was sedated and paralyzed. And I can't remember the last time we sedated and paralyzed a bronchiolitic, even the sickest ones. So, it's cool to see the differences and similarities. I see Hui Ying, you've had your hand up for a while, so I just want to make sure I'm not missing a question. I'm going to allow you to talk. Let me know if you had a question or maybe your hand is up accidentally. Hui? Okay, so I'm actually going to ask them to unmute. But in the meantime, we just hold on. We're going to ask our last question before we wrap up for the day. And that is from Melissa. Great question. How do you operationalize the process? Specifically, where do you start? How long do you have, Alyssa? So it's really the bottom line is get everyone in a room. Get everyone in a room together. And I think among this group, Carrie and Hallie were the originals, right? The original Pick You Up champions back in the day in 2014 when we started planning all of this. And they will tell you that we met on a bi-weekly basis and essentially just kept meeting and talking about what we wanted to accomplish. Now, we were in a different spot because there wasn't really any evidence that had really been established. There weren't a lot of examples for us to follow. So we had to start completely from scratch. But luckily, you guys don't have to start from scratch. There's not just Pick You Up as a model. There are many other examples. And if you go to that ICU rehab literature list, you'll see many other PICU rehabilitation models that have been set up. The key is getting in a room, coming up with a cool name, and then talking about what you want your program to look like. And I think the most important guidance I can provide, and we share all of this at our rehab conference, so please do join us. The foundations is if you've never been before, the main conference is for those who haven't been before and for the folks who attend foundations, but we cover all of this. I think the key is making sure it's every kid every day. I think people are often very tempted to focus on one specific patient population when they roll things like this out because it's easier. It's a smaller group of people. Maybe it'll be more feasible and doable. But the fact of the matter is that unless you apply it to every kid every day, you won't generate culture change across an entire unit. And it's the culture change that gives people a shared vision for collaboration and to continue to push each other to take it to the next level. So I think that's my kind of biggest advice. Anyone on the panel have anything to add in terms of getting people inspired and motivated?
I think
Hallie?
celebrating the small wins as well. As Sapna alluded to earlier, you know, everyone thinks of early mobility as walking the intubated patient, but not every intubated patient is appropriate to ambulate. So even just getting your less critically ill patient out of bed and walking and, you know, taking pictures if that's appropriate, or, you know, whatever it is to share that with the group. I think people then get more excited to, oh, look what we did. Oh, look what we did. And that excitement tends to rub off along the unit, but not always having those like, oh, if we can't mobilize the really sick person, what's the point? Mindset that will slowly shift culture.
Thanks, Hallie. Any other tidbits?
Yeah, I'll share. I think sharing the data is huge. I know personally as an RT, I despise doing chest PT, and we have found that getting a patient up just even to the edge of the bed it helps increase lung recruitment so much better. So I think it is well worth telling your RTs it's worth it. I mean, I would much rather do an activity that like inspires and makes the patient proud of themselves while recruiting lung than turning them side to side and tapping on them, which just doesn't work as well. So share the data is real. It works.
And for the medical team, the physicians and nurses, everyone out there, also not just don't tell, ask the RT, is this something we can make happen today? I ask the nurses, do you think we can get this child out of bed? Do you feel safe? Do you feel comfortable? And the answer may be, yeah, we're on it. Or it might be, oh, there's these issues. And we either figure out a way to work through them, or maybe today's not the day. So I think that's really, really important. Thanks, Steph. Carrie?
I also just wanted to mention, I think early on we would do team huddles before any like larger sort of intense mobilizations. And it gave everybody a chance to have a voice, to voice any of those concerns, for everybody to hear it, for us to work through those and make like a good group decision. And then we could easily also debrief after. And I think that when we were just starting out and just getting things going, it was a really good way of nobody feeling alone in being responsible for the mobilization.
And then to piggyback off what Steph said, my least favorite thing to do as a nurse is take care of a delirious patient. So when I move my patient around during the day, get them up, turn their room around so they can see the sun, I know that they're going to sleep good that night, and I feel proud about that. So that's what does it for me as a nurse.
I love it. Well, I think on that note, I think that's a perfect way to end. And none of us want to take care of a delirious patient. And I think one of the take homes, if you read our Pick You Up sustainability study that we published last year, is we decided that rehab's not just good for the patients, it's good for all of us. Coming to work in an ICU is really hard each and every day. And we found that Pick You Up, while it does increase workload, there's no question, because there's a lot of things to think about in the process, it helped the staff feel engaged and valued for the expertise that they brought to the table. And it's fun to watch kids do well. So we'll end there. Thank you so much for joining us. Thank you to our incredible panelists and to all of you for attending from across the world. We hope to see you at the ICU Rehab Conference. Have a great rest of the week. Bye.